Hey everybody, it's Rita with Simply Certified. I am so excited because today I'm going to talk to you all about diabetes coding and documentation concepts. I'm not sure if you all can see my entire screen. My taskbar is down there at the bottom, so just in case you can, it is 58 degrees and sunny here in Louisiana, and it is 3:51 p.m. on March 13th. Just a little bit of housekeeping before we get started. So, y'all, I made this presentation for educational purposes to serve as informational material and to kind of tell you guys on the proper way to use ICD-10 coding guidelines and some documentation concepts. It doesn't represent the opinions of anybody I'm associated with. For instance, my certifying organizations or anybody I may be employed with, except for, of course, maybe Simply Certified because I'm the owner. However, I am not going to be held liable for anything in this presentation if you misinterpret what I say, or if there are some changes later on to the information and the information is no longer valid. You have to take the information with a grain of salt and be a health professional and go do your research on it. If something sounds wonky, it might be outdated. You might be watching this next year or maybe 2 years from now. Something could have changed. So I'm not going to be held liable for how you utilize this information or interpret anything that I say. That being said, a little bit about me. So first of all, I always get asked about my certifications, and I'm going to get to that. I went ahead and just put all of this in the presentation because everyone asked anyway. And since this is a recording, you guys don't really have the opportunity to ask. So I do have a Bachelor of Arts in Health Services Administration that I got from Kaiser University. They're in Florida, really great school. I also have an Associate of Science in Medical Billing and Coding from Ultimate Medical Academy. I got my diploma first from the same school. I did start an Associate of Science in Clinical Medical Assisting at Kaiser. But on my last clinical rotation, I was working and working. I just couldn't do it. So if I go finish it, I'll have that degree too. Just one class, 4 weeks. Currently, I'm working as an internal auditor and I audit profi coders. Also, of course, I'm the owner of Simply Certified. And what I do there is I'm an educator like I'm doing right now and a consultant. That is iamsimplycertified.com. That's the main website. It's pretty shabby right now, so don't judge. Previously, I was a pediatric ED coder. That's the emergency department, and that's pretty interesting. Lots of things shoved up noses and in ears, and yeah, just some weird stuff that goes on in the emergency department, especially for children. Before that, I was a clinic coder at a major health system. I literally was responsible for an entire pediatric specialty hospital that even had a St. Jude wing. So I coded everything under the sun. I even did some customer service and denial follow-up stuff and auditing. I've done some transcription work. There was a lot of medical transcription, of course, but there was also legal transcription or transcribing business meetings, just various stuff, even captions for videos. It was pretty interesting. I don't do that anymore because I don't have time and you're paid by how much you can transcribe per minute, which, I'm pretty decent at it. I used to be a scribe. I'll get to that. Before that, I was a medical assistant at a dermatology clinic, and that mostly had to do with the degree I was pursuing at Kaiser University. And I know all of this sounds really wonky, but you'll see why on the next page. And I got my foot into the industry. I was already a certified coder at this point, but as a clinical scribe. if you're a coder, especially if you're newly certified and you have a CPCA, you know how hard it is to get that first coding job. And actually, being a scribe made me a lot better at what I do. And it's probably a big reason why I have so many credentials. I learned how to document like a provider should document, and I learned how to navigate electronic medical record systems like Epic and Athena like a boss. I even became a super user, y'all. So I was a clinical scribe in an emergency department for a while. It was a little bit overwhelming because that is intense. I was in a major city, so you can imagine gunshot wounds, lots of deaths, overdoses, stuff like that. And before that, I was in outpatient dermatology for a long time. I also did ENT and neurology and a few other things, but I wasn't consistent with those. Like the outpatient dermatology and the emergency department, that was my regular job. So I did multi-specialty. On to the certification. So you'll notice something strange on here is that I don't have CPCO listed after my name, but I do have it on my list. And that is because I just took the exam yesterday. I am 5,000% confident that I passed. So I went ahead and put it on here so I don't have to edit it later too much. However, I listed these from the most recent to my very, very first one, which was my CPC back in 2016. I'll briefly explain them all because, especially if you're a newbie, you're not really familiar with all of these different acronyms and credentials and certifying organizations. And even some experienced people aren't, familiar with things that are outside of what they do. So the very most recent one I got was actually last weekend, and I passed my CDEC, that's Emergency Department Coder, with AAPC. That is the American Academy of Professional Coders. Their website is aapc.com. The weekend before that, actually 2 weeks ago, I passed my Certified Professional Practice Manager, CPPM, from AAPC. At the end of last year, very end of December 2021, I took the CDEI beta exam. That is when they have the exam brand new and it's in a testing period and they only pick select people. You have to submit your resume and all of that jazz. So basically, I was a beta tester for this exam, and that is the Certified Documentation Expert Inpatient. So that's a CDI credential. AAPC does offer 2 different CDI credentials. Right before that, I got my approved instructor. That means you see a lot of people have something called a CPCI or a CPMAI. AAPC kind of did away with the -I credential and came up with approved instructor, where you can buy each credential license and teach individually. But anyway, that is what that is. And I did the CPMAI track, which basically I took a course about adult learning and brushed up on medical auditing and took a bunch of exams and did a presentation geared for adult learners and jumped through hoops and became an approved instructor. I also have something called a QMCI, Qualified Medical Coding Instructor from Q Pro. That's Qualified Professionals. I kind of got that because I was clicking around one day and I saw it and it looked interesting. So I got it to see what it was. And I use it because I earned it. And I may or may not maintain that one. But yeah, they have it's kind of like certifications, but they call them qualifications. So that's QMCI from Q Pro. I am a certified medical scribe professional. I have a passion for documentation, hence all the CDI and auditing and blah blah certifications on here. So why not? And that's actually, I think it's called American Healthcare Documentation Professionals Group. It's a mouthful. Y'all can Google that. I am a certified general surgery coder through AAPC. That one is a hard exam, y'all. It's long. I'm also a CDEO. That's like the CDEI, but it's outpatient. I'm a certified evaluation and management coder, CEMC, certified professional medical auditor, of course, and I work as one too, CPMA, certified outpatient coder. That exam is a lot of reading. I'm so glad they shortened the exams to 100 questions because that one, it had a lot of big cases in it. I'm also a certified rheumatology coder, CRHC. I really have a passion for rheumatology and dermatology. I honed in on my billing for a while, so I have three right here, like back to back. Certified professional biller from AAPC, certified billing and coding specialist from National Health Career Association, CBCS. And from the American Medical Billing Association, I got the certified medical coding specialist, CMCS. They also offer one for revenue cycle specialist or something like that. But yeah, it's a coding certification. Almost the entire thing is coding, but it's geared towards someone who does a lot of billing functions. It's a really cool one. I actually really enjoy having that one, and AMBA's a really good organization. I'm a certified risk adjustment coder. I really love diagnosis coding. That's HCC risk adjustment coding. I also have something called a certified expert professional fee generalist, CEPFG. That's kind of like that QMCI. I just kind of use it because I earned it and I got it to see what it was, and it was cheap. Why not? I'm a certified melanoma educator. There's, again, with my dermatology trend going there, I really have a passion about melanoma prevention and getting skin exams. So I went ahead and became a certified educator so I could teach people about skin health and looking out for the signs of melanoma. Right before that, I became a certified professional coder in dermatology. And before that, I got my CCA from AHIMA, the certified coding associate, and I'm kicking myself every day because I wish I had gotten the CCS. It's not much harder, and I'm fairly certain I could have passed it. But yeah, that's the ICD-10 PCS coding. It's facility geared towards facility coding. No CPT there. And of course, my very first certification was my CPC. And I got my A removed being a scribe who coded, which some scribes do fully document and code the record. And that was way back in 2016. Yes, I do move fast. Enough about me. Let's get on to today's topic. What is diabetes? So I put the definition of diabetes in here. It's a disease in which the body's ability to produce or respond to the hormone insulin is impaired, resulting in abnormal metabolism of carbohydrates and elevated levels of glucose in the blood and urine. So what does that really mean? So a patient with diabetes isn't really able to properly process and use glucose, which is blood sugar, it's sugar, from the food they eat. So like if you eat a banana, it's full of sugar, right? A patient with diabetes isn't able to process it right. There's different types of diabetes, and each one of them has a different cause. But the one thing that they have in common, all of them share the common problem of having too much glucose in the bloodstream. Some of the treatments for diabetes include medications and even insulin injections. Some types of diabetes, such as type 2, can be prevented by adopting a healthy lifestyle. That's not always the case, but sometimes it's true, just like with high blood pressure. Hot tips, hot tips, hot tips, right? Everybody loves hot tips. almost every coding question about diabetes can be answered by reading the guidelines. You're going to hear me say the word guidelines 500 times throughout this presentation. Diabetes is a great place to learn about the guidelines. And I don't mean just the diabetes guidelines, I mean the whole shebang, the whole coding guidelines. Because in diabetes coding, you cover every single body system. That's exciting, right? So for your convenience, at the beginning of this presentation, I put the guidelines. And I'm kind of annoyed because I can't get my taskbar to go away. I can't find that little hide the taskbar option. So the diabetes codes are actually located in chapter 4. And don't worry, I'm going to read whatever's cut off at the bottom here for you guys. And of course, I'll supply these slides and the recording for you. So in chapter 4 of the ICD-10 book, it's the endocrine, nutritional, and metabolic diseases, codes E00 through E89. Diabetes is located in this chapter. It's pretty much a disease of nutrition or the endocrine system, depending on the cause, or a metabolic disease. Something important about diabetes codes, and I'm not going to sit here and read all of the guidelines. You guys should be able to find the guidelines for ICD-10 online by searching for them and download them. So I highlighted the important parts, and I apologize to our podcast listeners because you can't see what I'm talking about. However, you can always purchase this video. Anyhow, in pink here, pretty little pink, you see I highlighted some really important points. So the diabetes codes, they're combination codes. It doesn't matter really what the type, but they're all combination codes. And if you're not familiar with what a combination code is, it's like when somebody has a disease like diabetes or say hypertension or maybe even chronic kidney disease or something. They have a diabetes, right? And then they have another disease with their diabetes or another symptom or, a complication. Well, a combination code smashes that together to explain the condition better. So like there's a code for hyperglycemia. It's an R code, but there's also a code for diabetes, right? Let's say type 2 diabetes, and I'm not going to specify it further, which is E11.9. But if a patient had, for example, type 2 diabetes and it was uncontrolled and they had hyperglycemia, you wouldn't use those two codes for, unspecified type 2 diabetes and an R code for the symptom of hyperglycemia. You would use E11 I think 65 because it's a combination code to describe a person who's having an exacerbation or a complication of their diabetes, which is the hyperglycemia. So that's pretty much what a combination code is. So be aware of that all diabetes coding, unless it's really vague, is a combination code. The next important thing to really hone in on is that you can assign as many codes within a particular category as you need to describe the complications of diabetes. So that means when it says a particular category, if a patient has type 2 diabetes, it's coding to E11 category. If they have type 1, it would code to the E10 category block. So if they have type 1 diabetes and they have, 10 complications of it, you're going to be coding 10 or more codes probably, but they're all going to start with E10. You're not going to have any random E11s or E08 or E13 mixed in. The particular category is the E10. So you're not going to mix those up, but you can have all the E10s you need to describe what's going on with this patient today. And today is another keyword, today, this date of service. The next thing I have highlighted here is sequenced based on the reason for a particular encounter. They should be sequenced based on the reason for a particular encounter. An example here is you're going to have, a patient may have come in for that hyperglycemia, and that's what they're coming in for. But the provider is also considering, the patient has other complications of this diabetes. They may even be addressed today, but it's not the reason that they came in, right? So in that case, you would use the code for that diabetes with the hyperglycemia as your primary diagnosis, followed by all of those complication codes. And it's just repeating itself over and over. You'll notice through the guidelines, assign as many codes from categories E08 through E13 as needed to identify all of the associated, I do believe this is conditions that I have no idea what it says. I'm very sorry. However, let's see, that the patient has. Woo! It went away. So when you see in the guidelines anywhere that something is being repeated over and over, and it's just changing out, like where it's saying here E08 through E13, it's really trying to point out that it applies to all the diabetes codes and that you should maybe really take this advice. The types of the diabetes are addressed in the guidelines. So the guidelines here, I didn't highlight it because I'm gonna go in depth on this later. But the patient's age isn't going to be the only factor you're going to consider about when you're picking your code for the diabetes. And another important thing that I wanted to point out, that it's commonly known as type 1 diabetes, usually when we talk about it presently, but it used to be called juvenile diabetes. Like everybody called it juvenile diabetes. And even farther back than that, people called it brittle diabetes. Like somebody with type 1 diabetes, they were brittle, they were going to break. Excuse me. So what do you do when the provider doesn't document the type of diabetes? So they just put diabetes in the note, or maybe they put like uncontrolled diabetes, right? So they're not telling us if it's type 1, type 2, or maybe it's some kind of secondary diabetes. Unfortunately, there is a solution, but it defaults to code E11 for type 2 diabetes. The patient may not have type 2 diabetes, but if it's not documented, it's not done, right? So it'll always default per the coding guidelines to type 2. So say the documentation says just diabetes with hyperglycemia. You're going to use the combination code in the type 2 category. Here's another area where the guidelines repeat themselves over and over and over, right? So there'll be another slide and the same information is going to be on it in a different context, and I won't read it again. But on this slide, I really wanted to highlight it because there's been some changes to the guidelines in 2022. So here you can see again in pink, if the documentation in a medical record does not indicate the type of diabetes, but does indicate that the patient uses insulin, code E11, type 2 diabetes should be assigned. So it's telling you again and repeating itself that if the documentation is unspecified, use the default code. And you're going to see that over and over again about the default code. So the other thing you're going to see over and over again is about insulin and oral diabetic drugs and injectable non-insulin diabetic drugs. Now, the changes that happened, okay, so in 2021, the old guidelines told us that if the patient took insulin, to code it to Z79.4. If the patient only took oral diabetic drugs, to code it, right, to Z79.84. And if the patient took, oral diabetic drugs with insulin, you would only code the insulin and drop off the code for the oral diabetic drugs. If the patient took oral diabetic drugs with a non-insulin injectable, you would code both of those together. And if the patient took insulin with the other injectable, you would still code both, but you'd never code the oral with the insulin. Now, 2022 comes along and the new guidelines state, and I highlighted the changes in blue. And forgive me if I copied and pasted wrong, because I was really, really trying to point this out for you guys. So here's what it says now. If they take the insulin, right, and they take the oral hypoglycemic drugs, you code it, which makes sense to me, because if somebody is only on insulin, they're a little bit better off probably than somebody who has to take both to control their condition. Or at least in my opinion anyway. It seems like, the more treatment that you have to add on, the more resistant that the diabetes is being to the treatment. So that only makes sense to me that they've changed it to where you code it all, because it better explains the condition anyway. So just a heads up on that when you see that a patient is taking long-term insulin, you code it. If they take oral anti-diabetic drugs like metformin, you code that too. If they take them together, you code them both. There are other injectable diabetes medications that are not insulin. And if the patient takes that long-term, you also code that. And you can code a combination of any two or all three together. That is what the new guidelines say, explained in a way that, is pretty simple. Code it. A note on temporary insulin. So there are cases, patients in the hospital and they might have an infection, or maybe they just had surgery, or they're taking steroids and their blood sugar is temporarily out of control. Maybe they don't even have diabetes, right? And so they're on sliding scale insulin in the hospital. And this insulin is being given to temporarily, right? They're not going to go home with it. They didn't come in on it. It's to get their blood sugar under control, because it's probably not going to go wonky again later. You wouldn't assign the code Z79.4 for this, because Z79.4, I want to explain it as chronic use of insulin. You can't, you're not really probably going to get off of it at this point once you assign that code. So like if somebody's got gestational diabetes and they're temporarily using insulin, you wouldn't code that. And if somebody, they're having a blood sugar problem because they just took massive amounts of prednisone, you're not going to code their long-term use of insulin, because they haven't been on it long-term and they're probably not going to continue to take it. So I want to talk about diabetes and pregnancy and gestational diabetes. These actually have their own guidelines, which I'm not going to cover in this section. This type of diabetes requires codes from the O chapter, which is conditions in pregnancy. And so the guidelines for that's going to be found here, where I referenced on the screen. It says see section I.C.15. So that's where you would refer to for that. I didn't highlight too much here, and I'm going to talk about this again throughout the presentation, and it is one of the things that you will see repeated over and over again in the guidelines, and it's the complications due to the insulin pump malfunction. Now, it's pretty much the same advice, whether it's an underdose or an overdose of insulin due to the insulin pump malfunction, except the codes you're going to use are going to be a little bit different. So here is what the guidelines say. So when you have an underdose of insulin due to an insulin pump failure, you should assign a code from subcategory T85.6. And that subcategory is for a mechanical complication of other specified internal and external prosthetic devices, implants, and grafts. That specifies the type of pump malfunction as the principal or first listed code, followed by code T38.1 0.3x6 dash. That means there is a 7th character. And that code is for underdosing of insulin and oral hypoglycemic anti-diabetic drugs. And the reasoning for that is it's telling us that the reason for the encounter, I mean, they wouldn't be here right now if their insulin pump hadn't failed, right? It's not giving them the insulin they need. The insulin pump failed. And then you code the diabetes codes after that for the type of diabetes and the complications. Our diagnosis codes tell a story, and these guidelines, they're there for a reason, and they're telling us how to articulate that story with our coding. The little note at the bottom that's not even bolded is telling us what should be a no-brainer for most coders is that after you assign these T codes, you have to code for the diabetes and the complications, which I've already said. So for overdosing, it's the same concept. So you need to list the first diagnosis as a T85.6 dash. There's more characters. So be careful. Don't just put T85.6 on a claim because you heard it in this presentation. There are more characters behind that if you see that dash. So this time it would be, they're having a malfunction resulting in an overdose of insulin, okay? And the next code would be for T38.3x1 dash. Again, there's another character there. Poisoning, because it's an overdose. Not this time, it's not an underdosing. The insulin pump was putting out too much insulin, right? So poisoning by insulin and oral hypoglycemic anti-diabetic drugs. Accidental, unintentional. Like this person didn't shoot up the insulin to try to kill themselves. Their insulin pump went haywire. So that code, the coding again, tells a story. And again, you would follow this by the appropriate diabetes codes from category E, whatever, E11, E10, the type of diabetes. So I changed up the screen a little bit on you here to see if you're paying attention. Something I really want to point out is that secondary diabetes always has some kind of cause. And you usually code that first. Like secondary diabetes is never used as a first listed diagnosis because it is a secondary condition. The guidelines pretty much, I don't know, they can be confusing, but I think it's pretty clear what the guidelines tell us. And here's some more repetition about in secondary diabetes mellitus, when someone's using insulin, oral hypoglycemic drugs, and injectable non-insulin drugs, it's the same thing. So it doesn't matter what kind of diabetes a person has, right? With the exception of type 1, and I will explain that later. But as far as type 2 diabetes and all of the other types of diabetes, when they're taking some kind of medication, you're going to code it. Whether it's 1 or 2 or 3 different types, you're going to code them all. So like I said, you wouldn't want to put a secondary diabetes category as a first listed diagnosis. The guidelines tell us how to do it, right? If we look at the guidelines, it gives us an example for post-pancreatectomy diabetes mellitus. So what this condition is a lack of insulin due to the surgical removal of either all of the pancreas or part of it. So like maybe they only took the head of the pancreas or something. But anyway, you would assign code E89.1, right? Because they have post-procedural hypoinsulinemia. And then you would assign a code from category E13 and a code from subcategory Z 90.41 for acquired absence of the pancreas as additional codes. Now, the reasoning behind that is, right, the they have post-procedural hypoinsulinemia right now, okay? But you would put the diabetes second. That's the secondary diabetes. But the reason that they have the diabetes, right? And the reason that they have the post-procedural hypoinsulinemia is the acquired absence of the pancreas. They had their pancreas removed. They weren't born without it, so it was acquired. So it tells a story. Again, everything is going to tell a story. So some types of diabetes are caused by drugs. And there are guidelines about secondary diabetes due to the drugs. You know, a lot of drugs can have some really bad side effects, right? And even if normally a drug is safe, maybe it was administered incorrectly or a big dose was given and it caused some problems. That can happen. So the guidelines tell us to see section I.C.19.E on how to code the adverse effects and poisoning, and section I.C.20 for instructions on how to report the external cause codes. Now, I know a lot of places don't do external cause coding, but it's a really good skill to have because a lot of places do. And if you get there and you don't know how to code external causes, you're kind of lost. All right, so enough with the guidelines. That was pretty much all of them. And again, I did not read them word for word. I explained them in a way that would be easy to understand and kind of pointed out some key things that would help you learn all of the ICD guidelines, not just diabetes. So about diabetes. Diabetes is caused by a lack of insulin or a resistance to insulin, right? Depending on which type you have. Insulin is needed for sugar, starch, and fat metabolism in your cells. Like you can't metabolize what you eat without it. It's not a good thing. Without insulin, sugar cannot leave the blood and enter the cells to produce energy. So, typically what happens is you eat something and you digest it, and the sugar goes into your bloodstream and it travels all around your body, right? And your cells take things from your blood, nutrients like sugar, and they need this sugar to function and replicate. So with when you have blood sugar or insulin problems, or usually both, you're going to have problems everywhere because your cells aren't getting what they need. With diabetes coding, I like to ask 4 questions. Now, you'll see later on in the presentation that some of these questions can be answered at the same time, and even some of them will answer the other one. So the first question is, what type is documented? What type of diabetes is documented? Now, hopefully it is documented and we don't have to default code like the guidelines kept repeating to us. So I'm just going to break it down a little bit more. Some of us aren't familiar with all of the other types of diabetes. There's many types of diabetes actually, and a lot of the terms can be confusing. And even there's things that are called diabetes that aren't actually diabetes. So here's a little breakdown, and there'll be more slides that look like this later. So I might sound like a broken record. These types on the screen are types of secondary diabetes. A note on the gestational type is that pre-existing diabetes in pregnancy also falls under this coding category, but gestational diabetes is caused by the pregnant state. It is a secondary type of diabetes. However, the guidelines for the O chapter, when you code it, it's a little bit different, but we'll talk about it. So, diabetes due to an underlying condition codes to category E08. If a drug or chemical induced the diabetes, it'll code to category E09. Now, I know that sounds a little bit similar, but the difference is it's a little bit different as far as the specificity, right? Other specified diabetes, it's usually always a secondary type. It's going to go code to category E13. Notice again that each one of these codes on the screen has a period and a dash behind it. That means it is not a complete code. Please never use these 4 codes like they are. So what does the code book say? Right? Now, this isn't, obviously, it's not a picture of the code book. But in category E08, and most of the diabetes codes are going to look pretty similar, you can see that I highlighted a bunch of stuff. When you flip to this coding block in your code book, you're going to see the same thing. It's going to look a little bit different. But this stuff is pretty much instructions on how to use this code. They're called instructional notes for a reason. So what it's telling us is to code first the underlying condition. And then to make it even easier for us, it gives us examples. So like congenital rubella can cause diabetes. So if the diabetes is caused by congenital rubella, this instruction is telling us to use code P35.0 first. And of course, always go to that code and verify it. But diabetes can also be called by Cushing's syndrome, which is another endocrine disorder. So you would code that first. And of course, you would go to that code and follow any instructions that might be under it. Cystic fibrosis is another common cause of diabetes, and so is cancer. And malnutrition can cause diabetes. We commonly think, when we hear diabetes, eating too much sugar and having type 2 diabetes, but not eating right or not eating enough can also cause it. And of course, as we saw in the example earlier, pancreatitis and other diseases of the pancreas can cause diabetes too. Then there's another instruction that I highlighted in green. It's telling us what the guidelines told us over and over. Use an additional code to identify control using either insulin, oral anti-diabetic drugs, or oral hypoglycemic drugs, which I believe that, I think they meant to put that Z79.899 code for the non-injectable insulin and typo there, where I got this information from. So just make a note of that this could be incorrect because it's duplicate information. However, it's telling us to code the drugs that they're taking. And like the guidelines told us, code whatever they're taking, even if it's 2 or 3, right? Now, in blue, there's something called an excludes one. And for seasoned coders, we know that this means don't code it together. There are cases where you can. It's very rare. The conditions do exist together. But for all other purposes, if you see an excludes one on something, you don't code it together. It usually can't exist together, or one is part of the other one. So it tells us pretty much, if you look down, don't code it with any other type of diabetes. Do not code E08 with E09. Do not code E08 with gestational diabetes because you can't have both kinds together. Do not code it with neonatal diabetes. Do not code it with category E13. Do not code it with category E10 for type 1 or type 2 with category E11. It's important to pay attention to what's in your book because it'll save you a lot of headache later. Category E09. Drug or chemical induced diabetes, right? So Again, it's telling us in our instructional notes exactly what the guidelines just kept screaming at us. Code first, poisoning due to drug or toxin. And then it gives us the codes to go look through to find out, what code to put there. Use additional code for adverse effect, if applicable, to identify the drug. And then it's screaming at us again with a 5th or 6th character, like, don't forget. Use additional code to identify control using, and there's your drugs again, right? And then it's telling us excludes 1, don't code with all of these other types of diabetes. And it pretty much lists every single type again. Category E13 is your other specified diabetes. And I have some really cool examples of this code and its different uses later, and how sometimes the same condition can code to a different diabetes category. It's wild. All right, so here we have different instructions. It tells us what it includes because, like I said, this code is a bucket and they just threw a bunch of stuff in it. So diabetes due to genetic defects of beta cell function. Diabetes due to genetic defects in insulin action. Post-pancreatectomy diabetes, post-procedural diabetes, and secondary diabetes not elsewhere classified. So I'm just going to straight up tell you this right now, that, there's a lot of evidence that type 1 diabetes is genetic, right? It's due to some kind of genetic thing, genetic defect, genetic hereditary condition. A lot of diabetes are linked to hereditary stuff, but that's not what this is talking about. Type 1 has a specific code for that, so you wouldn't code it here anyway. This is talking about genetic defects of beta cell function, genetic defects in insulin action, and other kinds of genetic defects that wouldn't fit into any other category. And of course, it needs to be documented, right? I mean, you can't just pull it out of nowhere. So of course, we're going to code the control with the drugs, and we're not going to code it with any other diabetes category. Here's a coding example. This was actually from the guidelines. The patient with post-surgical hypoinsulinemia, secondary to diabetes mellitus, right? And they are status post-pancreatectomy. The diabetes is from having their pancreas cut out, right? So you would code the E89.1 for the post-surgical hypoinsulinemia. If we follow what the guidelines say, next we will code the secondary diabetes code, the diabetes caused from having their pancreas removed. And then we would code the status post-pancreatectomy to let everybody know that, hey, this patient doesn't have a pancreas anymore. They have a history of having it removed. All right, so the last type of secondary diabetes, and we'll talk about probably the O codes a little bit more too, because there's 2 types of diabetes that happen with O codes. So category O24, and notice again, there's a period and a dash. This category is separated by when the diabetes is occurring and how it is controlled. So if you notice O24.41, at the end there, it says in pregnancy. O24.42, if you notice at the end of the description, it says in childbirth. O24.43, if you look at the end there, it says puerperium. So it's broken down by the stage in which the onset of the diabetes, right? So if you're pregnant and you have gestational diabetes, it's going to code to O24.41. Now, underneath the description of the code, I broke it down a little further, and you can see a pattern here. So I put a dash, a dot, and 410. Well, that's the end of a code, right? So you can see that 0.410 is diet controlled. 0.414 is insulin controlled. 0.415 is controlled by oral hypoglycemic drugs. And 0.419 is unspecified control when they don't say what the patient's taking or how they control it. But if you look down at code 024.42 for the diabetes in childbirth, gestational diabetes, you'll see the same pattern, except now instead of 10, 14, 15, 19, it's 20, 24, 25, and 29. And the pattern repeats throughout this code block: 430, 434, and 435, 439. Gestational diabetes develops due to a pregnancy-related state. But what if the patient already had diabetes before they got pregnant? What if they were a type 1 diabetic or type 2 diabetic or some other kind of diabetic, and then they got pregnant and now everything's worse? There's codes for that. Diabetes in pregnancy. So it's a little bit different than gestational diabetes, which is a secondary type of diabetes. Diabetes in pregnancy was already there, but you're still going to use the code from category 024, right? And then you're going to code the type of diabetes. You're going to use your E codes to code the diabetes and the complications and any, control if applicable. These are broken down by type 2 though. They might have pre-existing type 1 diabetes. So you would use a code from 024.1, or they might have, 024.0, right? Or they might have pre-existing type 2, and then you would use 0.1. Or maybe it's unspecified. The provider didn't really specify. They just said, the patient already had pre-existing diabetes in there. They're 24 weeks pregnant. So you would use 024.3. And then, of course, we just talked about 024.4, which is the gestational diabetes, not the pre-existing. And then for other types of pre-existing and unspecified, other types, you would use 0.8. And of course, that code does have more characters. And unspecified is usually a 9 at the end. And in this case, that's also true. So 024.9. And here's some examples. So you also have to, when you're coding anything for pregnancy, we really need the weeks of gestation and the trimester. And diabetes is no exception. So in our first example, we have pre-existing out of control diabetes in pregnancy and the second trimester. And they use long-term insulin. They're 24 weeks gestation. So the coding example would be 024.312 for unspecified pre-existing diabetes mellitus in pregnancy second trimester. They didn't say what kind of diabetes it was, right? So we're going to code it to unspecified pre-existing. But then we're going to default to the type 2 code, E1165, because the guidelines told us to use the default code of E11 for type 2 when it's not specified. So E11.65 for type 2 diabetes with hyperglycemia. And the reason that we're coding the hyperglycemia is the words out of control. Uncontrolled and out of control, it's a complication of high blood sugar. So it defaults to hyperglycemia. The next code we would assign is Z79.4, long-term use of insulin. The documentation clearly states that she's on insulin and has been. And the last code we would assign would be Z3A.24 for 24 weeks of gestation. In our next example, we have pre-existing diabetes, but this time it says type 1. And it's postpartum. So we would code it as 024.03 pre-existing diabetes type 1 in the preparium, because the documentation specified postpartum, and that's what the preparium is. And then our next code would be E10.9 for type 1 diabetes without complication. The documentation didn't specify any kind of complication, such as being out of control or hypoglycemia or anything like that. And of course, it didn't specify control either. And in this case, we would not need the trimester or the gestation because they already gave birth. All right, something to keep in mind is the codes from category O24.0, or mostly all of them anyway, they're going to require 6th and sometimes 7th character coding. So O24.0, it's pre-existing type 1 diabetes and pregnancy, childbirth, and of course the afterbirth period. I put in pretty aqua text here just to kind of drill it in again. Use additional code from category E10 to further identify any manifestations. And another note reminding everyone, these codes are broken down by pregnancy, trimester, right? Childbirth, and the preparium. You notice this slide doesn't look any different from the type 1 slide. See? Well, it does a little bit, but I didn't really say anything different. So this is pre-existing type 2 diabetes. So again, it's telling us, don't forget to code your E11 because they have type 2 diabetes and how the codes are broken down. And again, right? So O24.3. And this slide is a little bit different. The note that I want to point out is here is when you're using this code, it's because the type of the pre-existing diabetes was not specified. So it defaults to E11 per the coding guidelines. With gestational, which is pregnancy-induced diabetes, remember, a code from subcategory O24.4 should be assigned. And if you're going to code gestational diabetes, you're not going to use any other O24 codes because you can't have, I mean, you can have, but you know, gestational diabetes is something all on its own. You're not going to be coding pre-existing diabetes with it, if that makes sense, right? Codes from this set of codes includes diet and insulin control codes. So not only are they separated by being in pregnancy, childbirth, and the preparium, but they're separated by control too. So pay attention to that. Don't forget about the coding the control. I can't stress that enough. As an auditor, I see it so much. I know it seems like such a crazy thing for me to keep harping on and to remembering to code the diabetes, but I promise you, a lot of people forget. It's so easy to forget, especially if it's not something you code every day. So don't judge. I'm repeating it for a reason. It's important, and it really is hard to remember, especially, yeah, if you don't code it every day. So an example would be gestational diabetes in pregnancy, 36 weeks of gestation. It's controlled by diet and insulin, right? So I'm going to assign code O24.414 for gestational diabetes in pregnancy, because this patient's 36 weeks pregnant, right? It's insulin controlled. And then I'm going to assign the code for the weeks of gestation. O24.8. I really love our other specified codes. So this would be all of the other diabetes codes that you would want to code would fall under this bucket, and you would code them together. Our pretty much only important instruction here, besides don't miss, coding the treatment, the use of insulin and drugs, use additional code. Don't forget to code your diabetes. But if you notice, they don't put E10 and E11 here because this is an other code. So it would be your underlying, your secondary diabetes, and everything else that doesn't fit into type 1 or type 2. All right. So what if it's a little tiny baby with diabetes? Usually, type 1 diabetes comes on later in life, usually kids older than 6 months. What if it's a brand new, shiny, smelly, cuddly baby? Well, there's a code for that. It's neonatal diabetes is an actual condition. There's a P code for that, P70.2. What is neonatal diabetes? So I'm going to throw some verbiage up here at you guys. It's a monogenetic disease. That means it's caused by mutations in like one gene, just a single gene. And it's usually inherited. So it's kind of like winning the lottery. Neonatal diabetes is really rare. And it happens, before you reach 6 months old. Well, what happens in it is, like I said before, all of our cells need to eat sugar pretty much, right? Babies that have neonatal diabetes, they don't make enough insulin, and it makes their blood sugar go up, 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 up. Neonatal diabetes is mixed up a lot with type 1 diabetes, like I said, because they both happen in children. And type 1 diabetes is a lot more common than neonatal diabetes. So some interesting facts about neonatal diabetes. Half of the babies that are diagnosed with neonatal diabetes, they keep it for life. And when this happens, it's called permanent neonatal diabetes. It happens in about 1 in 260,000 babies in some places. Now, it's like other conditions, since it's hereditary, it might be more prevalent in some places than others. So like in some areas, you might see it even less than that. And in some areas, you might see it more. But the average it occurs is 1 in every 260,000 babies. For the other half of those babies, the condition just goes away when the baby's about 12 weeks old, or sometimes even sooner than that. But the thing is, it can come back later. And when it does, it's called transient neonatal diabetes. So fetuses, unborn babies that have neonatal diabetes, they don't grow as well as they should inside the womb. And they might be like really small for their gestational age. So you might have a full-term 40-week newborn who's a little bit small for a normal baby. It's something called IGER. Now, I like to call it IGER anyway. My twins actually had this, but it's you pretty much the restriction. It's restricted growth inside the womb, and it's called intrauterine growth restriction, IUGR. That's why I called it IGER. Some people would probably tear my head off for making up stuff. But anyway, there are many types of diabetes and confusing terms. Here's some more breakdown for you guys. All right. So I put a little diagram here because I like pictures. Pictures help explain things, and I know they help me learn. So you have autoimmune or genetic causes for diabetes, right? And if you trickle those down, it breaks off a little bit. So we have type 1 diabetes, which codes to E10. And then, of course, we have the neonatal diabetes, which codes to category P70, so P70.2. But then there's some more types that I haven't talked about yet. There's something called MODY. And what MODY, M-O-D-Y, means is maturity onset diabetes of the young. And then there's something that people call LADA, and I'm not making these up, I promise. LADA, latent autoimmune diabetes in adults. And some other terms that you might hear are double diabetes and type 1.5 diabetes. Currently, all of this stuff at the bottom here codes to category E13. So what's type 1 diabetes, right? You might hear in the medical world, in the coding world, something called IDDM, IDDM, insulin-dependent diabetes mellitus, right? Or you might hear juvenile diabetes. So type 1 diabetes is a chronic autoimmune condition, and it makes you unable to produce that insulin. So insulin's a hormone, and it's used to regulate blood sugar. So if you don't have any, you can't use the sugar that's in your blood. And people with type 1 diabetes experience diabetic ketoacidosis, DKA. You probably hear about that a lot in the drug commercials. Do not use if you have diabetic ketoacidosis, or let your doctor know if you have diabetic ketoacidosis. But you guys can look that up. All right. So there's different factors, what science and medicine tells us that causes type 1 diabetes. Nobody's really sure the exact cause. So genetics is a big thing in the cause of type 1 diabetes. It runs in families. I mean, that's a proven thing. But they also think that there's something that sets it off, as is true with a lot of autoimmune conditions. Like, you can be just hunky-dory, but you have some wonky gene, and then you catch a cold or something, and then now you have psoriasis or something else autoimmune. That's usually how autoimmune stuff works. Something that makes it angry, and then you have a condition that you didn't have yesterday, even though it was always there hiding. So even though it usually comes on in childhood, you can develop it as an adult or even a teenager. You can get type 1 diabetes at any time of your life, right? So there is a lot of research going on about a cure for type 1 diabetes, but as of right now, there is no cure. I know there's a lot of stuff going on with stem cells therapy, and that's a very promising thing. But right now, treatment focuses on just managing blood sugar levels, taking your insulin. A lot of type 1 diabetics get insulin pumps. And of course, diet and keeping a healthy lifestyle to keep the complications away. What are LADA, type 1.5 or 1.5 diabetes, double diabetes, and MODY? That's some weird stuff, right? What I just said. It sounds like I'm speaking another language. All right, so LADA. I'm putting this in here because even a lot of providers, they might have heard about this in medical school, or they may not have, but this is like really unfamiliar stuff to a lot of people, not just coders or any, health information management professionals, but even providers. So that's the reason I'm putting this in here, for when the weird stuff comes up. So latent autoimmune diabetes in adults, LADA, It's a slow progressing form of autoimmune diabetes. It's a lot like type 1, but it's not type 1. So in LADA, your pancreas kind of just stops making enough insulin. And they think that it's happening from it says insult in quotation marks here, but what happens is they think your body is attacking your pancreas like slowly over time, and you just like it doesn't want to work anymore because it's just damaged. And your own body did it. So with LADA, usually, it comes on when you're older because damage happens a lot slower, and it may or may not have a different cause than type 1 diabetes. It could be the same thing. They might find out later in research, but for right now, it's two different things, and it comes on slower. All right, so type 1.5 diabetes, it's also called LADA. So that's what people are talking about when they're talking about type 1.5. When they're talking about type 1.5 specifically, they're comparing it. I think they're more trying to describe the characteristics of someone who has, characteristics of both type 1 and type 2. So a patient has this later onset of some kind of autoimmune diabetes, but they have symptoms of type 2. Maybe they're obese, or there's an overlap there. And especially the overlap of being usually diagnosed in adulthood, and the gradual set-in, the slow set-in. So that's what that means. It just means it's kind of like in the middle somewhere. All right. The term double diabetes, DD, not sure why anybody thought it was a good idea to call it DD. It sounds like intimate wear. However, has been used to refer to individuals who have type 1 diabetes, who are overweight, but now they have a family history of type 2 diabetes, and they have clinical they have clinical features of insulin resistance. So basically, double diabetes means somebody who appears to have both types of diabetes, they just appear to have it, even though they're type 1, but they have to have that family history of the type 2. But that's what they're talking about when they say double diabetes. So MODY, maturity onset diabetes of the young. So this is something you inherit. There's 11 genes that can cause this, and all you have to do is have a change in one. Scientists, all of them think, right? Research, up to 5% of all diabetes cases might actually be due to MODY. Like they're talking about, people who they say have type 1 or anything else, type 2, but they think that up to 5% of all of those other cases might actually be due to MODY, genetic. As you guys can see, that all of the types of diabetes, they pretty much share a lot of features, even some overlap areas where things are different, but they're shared. Just like everybody else with diabetes, MODY patients, they have a lot of trouble regulating their blood sugar. So MODY is more like type 1 than it is type 2. But just like the other weird types, it can be confused with either one. So in type 1, the pancreas, like I said, can't make and release enough insulin. And in type 2, people have insulin resistance. They usually make enough, sometimes too much, but their bodies can't use it effectively. So they get insulin resistance. But so with type 2, people, it's true, they're usually overweight. Most of the time they're obese. But with type 1 and with MODY, that's usually not true. people are usually normal weight or sometimes even underweight. But if someone has MODY, or specifically MODY and type 1, but or any type of obesity really does matter. So an obese person with the gene mutations for MODY might get the symptoms of diabetes sooner than if they weren't overweight. So they could get it symptomatic 10 years earlier if they don't maintain a healthy weight with MODY. So you can actually delay the onset of symptoms with MODY by maintaining a healthy lifestyle. But it's genetic, so it's kind of like nothing you can do about it. It's not like type 2 where there's a high chance you can prevent it. Enough rambling about that. All right, from the code book again, category E10, this is your type 1 diabetes. The thing I want to point out here is the inclusion terms. All right, there's a lot of exclude terms, but really this isn't any different than any other category of diabetes. It's telling us don't code it with other diabetes codes or symptoms of diabetes, the hyperglycemia not otherwise specified. But what it includes, these are synonyms. These are terms you may see in documentation, especially from our older generation of providers or our more specialized providers. Type 1 diabetes is also known as brittle diabetes, or diabetes due to an autoimmune process, or diabetes due to immune-mediated pancreatic islet beta cell destruction, idiopathic diabetes, like an unknown cause, juvenile onset diabetes or juvenile diabetes, ketosis-prone diabetes. Like I said, DKA, that's a type 1 thing. So back to the types and the confusing terms. I made a little pie here for you guys. So type 2 diabetes is caused by insulin resistance, right? But there's a few things you got to get to, or even you can have together with type 2 diabetes before you get type 2 diabetes. What happens in type 2 diabetes is that you basically build a wall and your insulin can't get to where it needs to go, no matter how much you make, which is why people sometimes get low blood sugar even though they ate. They have insulin dumps. So with type 2 diabetes, which codes to category E11, right? That's not a complete code. Before you get that, and sometimes, unfortunately, they don't catch the prediabetes. But before you get there, your blood sugar's high. You have hyperglycemia. Now, they might catch it at that point, but if they don't, they keep checking it. You'll keep checking it, right? They might catch it when it's a pre-diabetic level. And what that means is your blood sugar gets high, and it might stay high for a little bit, but it's not getting to a diabetic level of high, and it's not hanging out there, right? So that's pre-diabetes. And once your blood sugar starts getting high to get into a pre-diabetic pattern, what happens next is you start becoming really resistant to the insulin. And when that happens, you can develop something called insulin resistance, which is also known as metabolic syndrome, which also has a code in the endocrine chapter E88.1. Now, at this point, there's no turning back. If you've reached insulin resistance syndrome or metabolic syndrome, you are you're resistant to insulin. There's no turning back from that. You can't fix it. You can keep it from getting worse. You can treat it, whatever. But it's not like you can just start eating lettuce every day and you'll magically become more receptive to insulin. It doesn't work like that. So the next stage in this process is the type 2 diabetes, where your blood sugars have reached a level of a diabetic and they hang out there and you have insulin resistance. What is insulin resistance and metabolic syndrome, and what's prediabetes? Pretty much just explain that, but here's some cool information about it. So insulin resistance is when your cells and your muscles, fat and liver, don't respond well to that insulin. and they can't use the sugar from your blood to make energy. So to make up for that, your pancreas makes more and more insulin. It just starts pumping out that insulin. And over time, your blood sugar level goes up, regardless of how much insulin you put out, because it's not really responding to it, right? Your cells are not responding to it. So insulin resistance syndrome, it includes a group of problems like obesity, having high blood pressure. Like there's criteria for it. There's a checklist for it. Just because you're resistant to insulin doesn't mean that you have the criteria to meet coding E88.01. So anyway, high blood pressure, high cholesterol, and eventually type 2 diabetes. 1 in 3 Americans probably have metabolic syndrome. I probably have metabolic syndrome. I'm not laughing at you guys. I love food. Prediabetes means that you have a higher than normal blood sugar level. It's not high enough to be considered type 2 diabetes yet, but unless you change something, people with prediabetes are a lot more likely to develop type 2 diabetes. And that's for adults and children, anybody, people, or maybe even cats. If a cat is a pre-diabetic and they don't fix the problem, yeah. Type 2 diabetes. What is it, right? So we always hear, somebody's grandma's diabetic, my aunt's diabetic, and that's probably what they have if they're, it's common. So type 2 diabetes is the most common type of diabetes. And again, it's an impairment in the way that you regulate and use that sugar as pretty much fuel. You've got kinks in the way you use your gas. So it is a long-term condition. It's chronic, right? It goes on for a long time, more than 3 months, maybe until you die. It's chronic. And what happens is too much sugar goes bouncing around in your bloodstream. And let me tell you, sugar, high concentrations of it, just like salt, are not supposed to be in your bloodstream. And stuff like that, it's sharp. It's sharp. Now imagine drinking a bunch of energy drinks and how you bounce around what I sound like right now that I've just had like a 16-ounce cup of coffee. Also that, all of the sugar is going into your cells and it's just like wonking them out. Okay. In type 2 diabetes, there's 2 problems kind of working together. So not only is your pancreas not producing enough insulin anymore, okay, but your cells are now responding poorly to it and they can't take in as much sugar. So since they can't take in as much sugar, it's running around in your bloodstream, trying to get in anywhere it can. And like I said, it's sharp. So imagine what it's doing to your nerve endings and your tissues. Type 2 diabetes used to be known as adult onset diabetes, but either type can come on during adulthood or childhood. There's tons of children out there now with type 2 diabetes. They're like, I'm talking about little kids. The next statement, people argue about it. It says there's no cure for type 2 diabetes, but losing weight, eating well, and exercising can help you manage the disease. I pretty much agree with this. Once you get diabetes, you have diabetes. If a doctor says, you're cured of diabetes, your blood sugars are fine, you don't need any further treatment, you don't need any modifications, I still wouldn't consider that a history of diabetes. And most providers that I know wouldn't either, but there are, mixed opinions on that in the medical community. Either way, as far as coding goes, there's no cure for diabetes. Once you have it, we don't code some history of endocrine. No, you just keep coding that diabetes because even if it's stable, it's not going to go away. I guarantee you, if you start eating ice cream 5 times a day, every day, your diabetes will come right back because it didn't actually go anywhere. You're just taking care of it. So, you might hear people say that you can cure it. but take that subjectively. It's a gray area. Maybe temporarily cure it, keep it from blowing up. I don't know. Anyway, so yeah, there's no cure for it. If diet and exercise aren't enough to manage it, you might have to start medications and insulin therapy that the guidelines keep yelling about. So this code here, E88.81 metabolic syndrome, a synonym for it is dysmetabolic syndrome, and sometimes they put an X behind it. So you might see it with the or without the X. And you might see it called insulin resistance or insulin resistance syndrome. There's instructions here. Use additional code for associated manifestations such as obesity. It's important because, usually somebody's not going to have metabolic syndrome and be rail thin. It's important to report that. And there's an excludes note on this for the parent code of E88. It's telling us not to code histocytosis X, which is chronic. And that's a cancer code C96.6. And it's also telling us, not only use associated codes for manifestations such as obesity, but any associated conditions, like diabetes. R73.03, pre-diabetes, and you might also hear it called latent diabetes, like diabetes type 2, just hanging out in the shadows, waiting to strike. Yeah. Anyway, so this code didn't really have anything important under it. However, the parent code, 1 digit earlier and 1 digit earlier than that, right? They have notes, which are excludes notes. So it's telling you don't code anything from this block itself. You don't want to code this with diabetes. You can't have pre-diabetes and diabetes. It's a spectrum. So like once you move past pre-diabetes, you have diabetes and there's no going backwards. So you don't code them together ever, right? And it's telling us also don't code this with post-surgical hypoinsulinemia because pre-diabetes would suggest you're starting to get like type 2 diabetes. So it doesn't mix with post-surgical stuff, right? And the neonatal diabetes, I don't know how much earlier you can get diabetes than the neonatal period, but yeah, you can't have pre-diabetes and neonatal diabetes. So excludes note on R73.0. So anything that starts with R73.0, no matter how many characters or what character is behind that 0, there is an excludes note. You're not going to code it with abnormal glucose in pregnancy. You can't really have both. Like if you're pre-diabetic, you have abnormal blood glucose, right? And of course, like I said, you can't have it with other types of diabetes. You can't be both. It's spectrum. You wouldn't code this with dysmetabolic disorder or your metabolic syndrome. It's two different things. Most people, that have the dysmetabolic syndrome, they end up with diabetes. So you wouldn't code them together. It'd be kind of redundant. Glycosuria, that means PP sugar. You got sugar in your PP. That's kind of an obvious. If your blood sugar is high, you're going to have glucose in your urine. And of course, hypoglycemia, low blood sugar. High and low blood sugar is going to be an inherent part of being pre-diabetic. It's a symptom. Type 2 diabetes. This includes diabetes due to insulin secretory defect. So if you have a defect in the way you secrete insulin, it's type 2. Diabetes not otherwise specified. Diabetes unspecified. This is your default code. Remember the guidelines yelled it at us. And insulin resistant diabetes. Don't forget to code your control with your insulin and your other drugs. And of course, do not ever code type 2 diabetes with any other type. They don't play well together. They can't be in the same room alone. All right, so here's some weird types of diabetes and not actual types of diabetes that people may have heard about. I'm going to explain them to you. So we have something called diabetes insipidus. It's not a true diabetes, right? It just acts like it. It's not even related to diabetes. This codes to, there's actually 2 different codes for it depending on the cause, right? So patients with diabetes insipidus, they're really thirsty and they pee a lot. People with the other kind of diabetes, real diabetes mellitus, they're really thirsty and they pee a lot. So that's kind of a shared thing there. And it's why it has its name. It's diabetes-like, but it's not real diabetes. Other symptoms might include getting up at night and running to the bathroom or peeing in the bedwetting. So what it is, diabetes insipidus, it's a disorder of salt and water metabolism. It's not a disorder of the sugar. It's salt. So salt and water metabolism, and it happens when your body can't regulate how it handles your fluids that you take in. So it's caused by a hormone thing. So like you've got a hormonal abnormality, and depending on the type, right, it has a different code, and the treatments will be different. And treatments could include hormone therapy, a low salt diet, and drinking more water. So if it's caused by your kidneys, it's called nephrogenic diabetes insipidus. And the code for that is N25.1. If it is not caused by your kidneys, it's just regular old diabetes insipidus, and it goes into the endocrine chapter E23.2. All right, type 3 diabetes. This is another make-believe type of diabetes, but is actually a term. It's a coin used to describe something, right? So diabetes type 3 is used to describe the relationship between, it's people that have type 1 or type 2 diabetes, but they also have Alzheimer's. So it's a person with either type 1 or type 2, usually type 2, and they also have Alzheimer's. So it's not an actual type of the type of diabetes is just used to describe someone who has diabetes, also have Alzheimer's, and it's really important because there's a lot of research being done, between the links of Alzheimer's and diabetes. So it's not a real thing. Just so you know, do not look for a code for type 3 diabetes. There is not one, and it does not code to an E code. Type 3C, though, it is a real thing. So that goes back to your secondary diabetes codes. And depending on, either or the actual cause of it, it's going to be E08 or E13. So type 3C happens when your pancreas stops producing insulin because you either have cancer in it, or you have pancreatitis, or you have some kind of other illness, or you've had an operation such as, any kind of trauma to it, like a partial removal, like you remove a piece of it or the whole thing. So depending on those circumstances, you would refer to your guidelines and it would code to E08 or E13, type 3C. That is not a fairy tale type diabetes. They should have just called it type 4 so you don't confuse it with Alzheimer's. Okay. The next question of diabetes coding, are there additional codes required? You guys can probably see now that the guidelines and the coding instructions just keep yelling at us to code more stuff. You can answer this question by looking at everything that I put pretty colors on in the previous slides. So additional coding, right? Check the instructions for code first, code also, and use additional code notes, right? For example, to answer the question about additional coding required in medications for codes in the E11 block, we look at this note. Use additional code to identify control using insulin and the oral anti-diabetics. Or like in category E09, we look at this note. Code for poisoning due to toxic drug or toxin. It tells us what to do and what other codes to put. Or we look to this note here, use additional code for adverse effect, if applicable, to identify the drug. I mean, you got to code them both together anyway, but there's your additional coding. The book tells us what to do all over the place. And with that question, are there additional codes required? We can probably answer the other question, what kind of medications and treatments are being provided? That's where we're looking for our insulin, our oral anti-diabetic drugs, and our non-insulin injectables. And the last question here too is going to be answered in the same fashion. So diabetes medications, again, if taking both insulin and oral, code both the insulin and the oral. If taking insulin and other non-insulin injectable, code insulin and Z79.899 for the non-insulin injectable. And if oral and other injectable, code both of those too. I wrote again on here to remind you that in 2022, the guidelines have changed. So whatever you've burned in since the introduction of ICD-10 about these drug guidelines, please erase it from your head. It changed. So yeah, the code for long-term current use of insulin again is E79.4, right? And that does have excludes 2 notes on it, even though you are supposed to code them together per the guidelines. There are parent code notes on Z79, so please pay close attention to that. All right, are there any complications documented? And this goes hand in hand with the additional codes required thing, because our guidelines tell us to use as many codes as necessary from the category to explain. All right. In the beginning of the presentation, I said that diabetes was a perfect way to learn coding. And this is a perfect example why it affects every single body system. Some of these codes here, they do expand for, based on severity, laterality, muscular edema. I'm going to go over that as I go through the codes. But just like with the O24 codes, there's a pattern here. So if you see, regardless of the category block, so it could be E10, it could be EO8, it could be any diabetes code I'm using here, any type, right? But I used E1X to say, this is a generic diabetes code. Okay, so imagine any diabetes code here, 0.0. 0.0 is your hyperosmolarity, right? Except for in type 1, there's no 4th digit 0. That's the only exception. Okay, so 0.1 is ketoacidosis. Any diabetes code, 0.2, this is your kidney stuff. So your diabetic nephropathy, your chronic kidney disease, like for instance, type 2 diabetes with CKD is going to be E11.22. And of course, you're going to code your CKD and follow all of your instructional notes for that. 0.3, that's your eyes. So that's where your retinopathy and your glaucoma is going to be. And that is where your codes are going to be, separated by severity, laterality, and macular edema. 0.4 is your neurological. So your neuropathy with gangrene and your gastroparesis, because even though, that's a stomach condition, it's the nerves in the stomach that are being damaged. So that's going to fall under 0.4 as your 4th character, right? All right, so 0.5 is your heart and your circulatory. So that's your hypertension and your angiopathy. Now this one does have the combination code for gangrene in it. I know I said neuropathy, you can, have that overlap there, but there's no code for that. The actual code goes to the angiopathy or the angiopathy, however you guys want to say that. So just keep in mind that it's with or without gangrene there in the 0.5 as your fourth character. So fourth character 6, that's other specified complications. So your joints, your skin, your mouth, low blood sugar, high blood sugar. So I put a little star there, making a note that that's your arthropathy and your dermatitis, your ulcers. So 0.7, there is no fourth digit 7 in diabetes codes, not at all, none whatsoever. So please never, ever, ever assign a fourth digit 7. You are wrong. No matter what, there's no guidance ever that's going to tell you to do that. There's no code book with that code in there. I've seen it happen. Please don't do it. 0.8, unspecified complications. Okay, this is when they have complications and they could even be specified, but you don't know where else to stick them. They're either very vague, they're ambiguous, they're not specified at all. You know there's complications, but you don't know what they are, can't describe them. It's 0.8. You're probably never going to use this code or not much at all. I hope not anyway. And the 0.9 too, unless that diabetes is stable, I hope you're not using this. So 0.9 is for no complications whatsoever. This person's a diabetic. Everything's hunky-dory. It's not complicated. Or the default code when they don't specify, like the guidelines screamed at us. Complications, complications, complications. Code for all the complications in the documentation. Don't miss any. The advice from the auditor here is keep an eye out for diabetes complications and all of the associated conditions, but never, ever, 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 ever mix up the categories. Again, do not code E08 with E10. Do not code E10 with E11, but do code all the complications of type 2 diabetes if they're documented appropriately. For example, glaucoma and type 2 diabetes requiring insulin is documented, as well as the patient having diabetic ESRD and being on dialysis. That's a lot of codes there, right? So for this, we code E11.39, E11.22, H42, N18.6, Z79.4, Z99.2. And I know I just rattled those off really fast, but you're going to see why in just a second, because I'm going to break it down slowly. So I copied the documentation and I copied the coding here, and now I'm going to explain it in pretty little codes. So I chose code E11.39, type 2 diabetes with other diabetic ophthalmic complication. That is such a weird word. I wanted to say never mind. Use additional code to identify manifestations such as diabetic glaucoma. So it's telling us right here, when we look up our diabetes code, to use an H code. We have to code the glaucoma, right? Our other notes are telling us also, don't code this, do code that, okay? So keep going. This patient also has ESRD, and there's a combination diabetes code for that, right? And because we're supposed to code all of the complications and other conditions, we're doing it. So E11.22, type 2 diabetes with diabetic chronic kidney disease. So the instructions here are telling us you have to code something from the N18 category because we need an additional code to tell us about this chronic kidney disease. All right. But we're not going to code it yet. Next, we're going to code that glaucoma that it told us to code first, right? So code H42, glaucoma and diseases classified elsewhere. Because it's in diabetes, it's in a disease classified elsewhere. All right, so the instructions here, it says code first underlying conditions such as amyloidosis. If we skip down, we see diabetes. So we know we're right in coding that diabetes because this is telling us code it first, and we've already coded it. Next, we're going to code that in 8.6. The instructions on the previous page pretty much told us to and gave us the code range to look in. N1 8.6 is for ESRD, that is end-stage renal disease. Now, usually these patients are on dialysis. Sometimes they are not, but usually they are. So look for that in the documentation, because the instructions also tell us to use an additional code to identify dialysis status. Z99.2, it even tells us where to go find it, right? Under the parent code notes for N18, we see other instructions like code first any associated diabetic chronic kidney disease, which we've already done, but we know, again, we've done it right. And of course, you would code hypertensive chronic kidney disease, which also has combination codes, but this patient hypertension was not documented. That's a great example of instructional notes right there, right? Use additional code to identify kidney transplant status if applicable, which this patient doesn't have a transplanted kidney, but that is important to pay attention to because a lot of the times they, believe it or not, do. All right, next we're going to code the long-term current use of the insulin. Our guidelines have told us to. Our coding instructions on at least 2 codes have told us to. And next, we're going to code the dependence on the renal dialysis. Our guidelines also tell us to do that, and so do our coding instructions, because this patient does have ESRD and they are on dialysis. It's documented. Under the dialysis code, you can see some types of dialysis that are included and some excludes notes, which is really interesting. So that is why you sequence the codes that way. And complications from insulin pumps, I know I already talked about this in the guidelines, but I just want to kind of repeat on it again, that you really do have to code it a certain way. So you're going to code the complication code first. So that's from T85.6, right? And then you're going to follow it by, either the underdosing or the overdosing code for that, followed by the diabetes codes and any drugs that, code as many codes as possible. Now that I'm done harping on the guidelines and drilling that in, I want to talk about risk adjustment and clinical documentation concepts for a little bit. So why is that important with diabetes? That's important because of all of these combination codes and all of these other systems. You're going to have a lot of codes when you're coding for diabetes that isn't stable. Let's just say that. And that's important because a lot of these codes are HCC codes, meaning your documentation has to have some meat. Ooh, what is meat? I like to call it meat on the bones, and I use this concept across all areas of coding, not just risk adjustment in HCC or CDI. I use it everywhere. So meat means monitor, evaluate, assess, and or address, and treat. And here's a little tool. I actually made this cheat sheet myself. You can find it in my Etsy store by itself or as part of, E&M or coding reference packets. So MEET's a common acronym utilized by coders to identify documentation that supports coding accuracy. So including one or more of the MEET details in a face-to-face or telehealth visit for each condition that requires or affects patient care, treatment, or management will help you simply capture risk adjustment codes. So, risk adjustment documentation really isn't that hard. It literally takes 1 sentence. So you're looking for places where the provider documents, or you want to teach your provider to document where they monitor the signs, symptoms, or they're ordering or reviewing and referencing lab tests, or the progression of the disease or the regression maybe. They want to document how they're evaluating those test results, the effectiveness of the medications. They're evaluating the findings of the physical exam and the different responses to treatment. They want to document how they assess or address the problem by documenting the discussions that they have with the patient or other providers, acknowledging other medical records, reviewing the records, documenting the status or the level of the conditions and the counseling. They want to document how they're treating it, how they prescribe medication or they continue medications for stable conditions, how they refer patients to specialists for further treatment, or they put an order in for a consultation for something maybe that they can't quite handle right now and they need advice on how to handle it. They send you for a surgical or a therapeutic intervention. They document, we're going to plan for a surgery, or we're going to plan for this therapy, maybe light box therapy, or they document how they plan to manage these conditions. I keep saying document because that's what this really is. So here's some examples, and they're really, really simple, little one-liners pretty much. Congestive heart failure, CHF stable, can continue the same dose, right? So these are not diabetes examples, but I put this in here because on the next page, we look at the 4 elements again, right? But next I want to see what meat looks like. What does the meat look like with diabetes? Okay, so best practice with diabetes anyway, not hypertension. Type 2 diabetes mellitus with chronic kidney disease, stage 3. Blood sugar well controlled on insulin, 20 units a day. No change to the current treatment plan. Okay, the next one is just enough meat on the bones. It's really, really skimpy. I wouldn't recommend it, but it's enough to get by. Provider documents type 2 diabetes with CKD 3, stable, continue with insulin. Where's the meat? Where's the meat? Let's go to the grocery store. Where's the meat? Documentation with meat on the bones leads to accurate coding. Meat terminology, controlled or poorly controlled. So in this example, we can see, I pointed out some keywords here. Patient's diabetes is controlled. Controlled on what? Novolog 20 units daily. Is the condition stable or unstable? So repeat GFR is unchanged. Patient has hypertensive CKD stage 2. So is the condition stable or unstable? It's unchanged. It's stable. Or maybe they were unstable and it's unchanged. They're still unstable. It's unchanged. This is where you would see words like worsening or improving or increasing. Is the condition acute, chronic, or acute on chronic? Patient's heart failure is chronic and stable. Or maybe, it's a diabetic patient and they have chronic kidney disease, but they're having an acute kidney failure. That would be acute on chronic kidney disease. There's, more codes to use for that. Meaty problems. So problems when it comes to getting enough meat on the bone. So common diabetes problems, as far as documentation go, is problems related to hyperglycemia and hypoglycemia. Poorly controlled, out of control, or inadequately controlled defaults to coding as hyperglycemia. All of that verbiage means high blood sugar as far as coding is concerned. So if the provider means something else besides high blood sugar, when they say poorly controlled, out of control, inadequately controlled, or uncontrolled, they need to be more specific. ICD-10 requires a physician or other practitioner to specify uncontrolled as either hypoglycemia or hyperglycemia. ICD-10 uncontrolled diabetes by hyperglycemia or hypoglycemia is considered a diabetes complication and therefore has a combination code. A little bit of extra knowledge about diabetes, and I'm getting excited because we are at the end of this presentation. I've been talking now for a while. Did you know and I hope you did because I said this earlier, E10 type 1 diabetes has no 4th-digit 0 code. Did you know that gangrene means the death of tissue due to lack of oxygen? Insulin is an anabolic hormone, and without it, you die. There is no category E12 in the ICD-10, and I speculate. Now, this may or may not be true. I do not have a source for this. Please do not quote me on it. But it's probably because they're going to try to add in LADA and MODI and all of that special stuff there. 1 in 10 Americans, actually a little bit over 1, it was 1 point something, more than 1, but less than 2, have diabetes. That's all types, not just type 1 or type 2, just all types. 1 in 3 Americans have pre-diabetes, but they think that number is a lot higher. Actually, probably 2 out of 3. 1 in 3 Americans have pre-diabetes. 30% of people with prediabetes or any other type of diabetes had chronic kidney disease in stages 1 through 4. And fewer than 25% with moderate to severe chronic kidney disease, stage 3 or 4, were aware that they even had any kind of kidney problem or diabetes for that matter. All right, we're at the end of the presentation. I want to urge you guys to check out my merch. I do have other products too in a different store. Please note the URL for the merch store where you can get coffee cups, backpack shirts, hoodies, office decor, even some beach towels, right? It's IamSimplyCertified.store. This is my spring store, and it only has merch. I have another store that has coding tools and references. That is on Etsy. So the Etsy, where you can find tools to do your job and make your life easier, even some of them are very, very pretty, is simplycertified.store. Notice I am is missing from the URL. So simplycertified.store, just simplycertified.store. You can find my podcast, anchor.fm/IamSimplyCertified. The main website for Simply Certified is IamSimplyCertified.com, not .store, IamSimplyCertified.com. I'm on Facebook, facebook.com/IamSimplyCertified. I do have a personal account there too. I don't mind people adding me sometimes. Don't go crazy, guys. We're on LinkedIn, Instagram, Twitter, all of that good stuff. You can find those links all over the other links I just gave you. But, you know, I can keep bringing you presentations like this if you buy my stuff, in all honesty, or just, you know, support us with donations. You are here watching this video because you just paid some money to watch it, I'm sure, unless you're one of the lucky people who got to see it for free or saw me at a local chapter event, or you're listening on the podcast for free where you don't get to see all of the examples and slides I've been showing to the people who paid to be here. So yeah, stay tuned. My next webinar, I'm deciding between a few topics, but I do think it's going to be a quick start guide for new coders. It's an expansion on my 15-minute quick start guide for new coders, but I've added a lot more stuff and I'm going to do some walkthroughs with that one. Or I'm going to do a topic near and dear to my heart, which is going to be Ehlers-Danlos syndrome and common comorbidities that go with that. It's going to be really similar to tonight's presentation, where I talk about the conditions in depth, you know, what causes, who treats it, how to treat it, whatever. I might even have some patient testimonials. I have Ehlers-Danlos syndrome, so I belong to some support groups, and my zebras there are helping me out with some ideas to talk about. Thank you guys, by the way, my zebras. Shout out to you guys. So I hope to bring that out. I'm not sure which one I'm going to do next, though. The guide for new coders or the Ehlers-Danlos syndrome. because May is Ehlers-Danlos Awareness Month, and there's a lot of different kinds. I think 16 now, and there's actual very specific codes for that as of last year. Yay. Anyway, so you can contact me. You email me, Rita at iamsimplycertified.com. Go to the main website. It's right there. And there's the LinkedIn. To request a copy of this presentation, you can totally have the slides. That's cool with me. You paid for it. Shoot me an email. I look forward to presenting to everyone again soon. And if you do have any questions about the presentation, please do email me, and maybe I can put the answers, record them in a podcast. I'll definitely email you back, or I'll put it in a future webinar. Thank you, everybody, for taking the time to attend this webinar. I'm really excited. It was my first one. It's a long one. My voice got tired. Thank you for, sticking through it with me. Appreciate it, and good night.